All right, looks like we have some more folks who are joining us, but let's go ahead and start today's PHSSR Research in Progress series. Our topic today, as you can see via the screen, is response willingness among the public health workforce and emergency preparedness laws. I'm Rick Ingram. I work for the National Coordinating Center for Public Health Systems and Services Research. I'll be moderating today. And our presenter is Daniel Barnett, MD, MPH. Daniel is an associate professor in the Department of Environmental Health Sciences at the Johns Hopkins Bloomberg School of Public Health. He also has a joint appointment in the Department of Health Policy and Management. He is affiliated with the CDC's funded Johns Hopkins Center for Public Health Preparedness, and his research interests include evidence-based approaches to enhance public health emergency preparedness and response systems. Daniel received his MD degree from the Ohio State University College of Medicine and Public Health. He has an MPH from Johns Hopkins, Bloomberg School of Public Health, and he's also a graduate of the Johns Hopkins General Preventative Medicine Residency Program. And you can see our agenda today. We're going to start with Daniel, then we'll have some commentary from some of our respondents. Then we'll do questions and discussions, as well as kind of just a brief plug for future webinars and announcements. Anyway, so our presenter today is Daniel Barnett. And Daniel, you want to go ahead and start?
Yes, thanks, Rick. Well, hello, everyone. It's a pleasure to be presenting on this Robert Wood Johnson Foundation-funded research, and I want to thank the National Coordinating Center for PHSSR on behalf of my research colleagues and me for the opportunity to present this work in progress. And as Rick mentioned, this topic is actually quite a timely one, given current events regarding Ebola, and I'll weave that into the discussion during the course of how state laws specifically may apply to current events. So the title of this webinar is, as Rick mentioned, Response Willingness Among the Public Health Workforce and Emergency Preparedness Laws. And by way of background, my colleagues and I at Hopkins have been looking for a number of years at the issue of willingness to respond to public health emergencies as opposed to ability to respond. I want to acknowledge my co-researchers, Dr. Lainey Rutko, Dr. Jan Vernick, and Carol Thompson, who've been really integrally involved for many years now in this research, including the current project. And so by way of background, my colleagues and I began looking at this issue of willingness to respond, or gaps in willingness to respond to public health emergencies, actually even before Hurricane Katrina. So in 2005, we did a pilot study of local health departments in Maryland, in which we found that approximately half of those workers indicated they'd be unwilling to come to work in an influenza pandemic scenario. At the time, of course, that was H5N1 that obviously preceded, which is, by the way, still percolating, and obviously preceded 2009 H1N1. So I'm going to, as the first learning objective today, going to provide a little more background about why response willingness represents, frankly, a threat to national and international health security in terms of gaps in response willingness, and why it's important to, secondly, understand the relationship between state-level emergency preparedness laws and willingness to respond among local public health workers. And then thirdly, as the final learning objective, we'll talk about and ask people to hopefully be able to discuss how this discrepancy, which may exist between workers' perceptions of what laws are on the books in public health emergencies and what laws actually are on the books, how that may affect local public health workers' willingness to respond. So the reason this is obviously so timely, right from today's headlines, as it turns out, is because we're seeing public health emergency laws enacted or being implemented at the state level as we speak with regard to quarantine, for example, of individuals who have treated Ebola patients in West Africa, and the potentially cascading effects that laws can have on even potentially willingness of those workers who've been quarantined or coming back to come or to basically serve in the future in West Africa, and for other people who had been considering doing so to consider serving in that capacity. So these ripple effects are international, not just national, but we're going to focus on the data that we have in front of us that speak to national level laws in the U.S. and also weaving in potential broader implications of those. So here is a slide from the Institute of Medicine. Was originally produced in 2002. It was revised in 2008. The take-home message from this slide is that there's a public health emergency preparedness system, which has as its hub the governmental public health infrastructure. So as we've all been following the news about Ebola, a lot of the focus has been on hospitals, but really the Institute of Medicine rightly characterizes governmental public health agencies as the hub of this system. And the other players in this system, critical players of course, include hospitals and the other bubbles that you see. There's an old expression that all disasters begin locally, and that is no less true of infectious disease as it is for other kinds of scenarios. And so the local health department really represents the centerpiece of the response infrastructure for events like Ebola or other kinds of emergent infectious disease, or even other disasters that affect public health across the all hazards continuum. A few years ago, my colleagues and I put together a concept paper based on this model using a very common catchphrase of ready, willing, and able, to really identify what are the key factors that allow us to define a quality response to a public health emergency. And while these terms may be simple, they have actually powerful meaning when it comes to our subject today, which is law. And I'll talk about each of these briefly in turn. So this is a Venn diagram, obviously, and the ready circle includes law. So do we have laws on the books at the state level or otherwise that speak to giving public health the resources it needs to perform its job effectively and optimize response? The second bubble includes knowledge and skills. So there's been a long-standing assumption nationally and internationally when it comes to preparedness training for events like Ebola or other threats. And that assumption has been that if you train someone how to look at anthrax under a microscope, that they'll necessarily be willing to come to work to look at anthrax under a microscope. And if you've just been noticing some of the headlines lately, we're seeing that assumption is a very dangerous one to make. Just a few examples of some news headlines that have emerged recently. There was an 11th hour nearly enacted protest or a walkout among Liberian healthcare workers who were concerned about not receiving hazard pay for their work. That was thankfully canceled at the last second. There were reports of widespread workforce absenteeism in a New York hospital, which is currently treating a physician from New York City who served in West Africa in treating Ebola there. There was a report in The Guardian UK of widespread workforce absenteeism and protests in a large hospital in Madrid where a nurse contracted Ebola after having taken care of a priest who had been infected. There were reports of cleanup workers in Dallas who refused to remove the sheets from the patient's home in Dallas who tragically died of Ebola subsequently. So we have even current examples of gaps in willingness to respond that can threaten health security. And that's why I'm going to be focusing the rest of the presentation on the interface between law and attitudes, specifically willingness to respond and particularly among the local public health workforce. So I just want to begin with just some overview thoughts regarding the local public health workforce. So as I mentioned, local health departments, or LHDs, are really at the heart of the governmental public health infrastructure. And there's been a growing body of research, not just from our group at Hopkins, but from others, that really point to concerning deficits about willingness among local public health workers towards a variety of threats, ranging from infectious disease to terrorism-related threats. And this is a concerning situation because our local public health workforce, as we talked about, is really the bedrock of the system that Institute of Medicine has described. Leading deficits that have been identified behind gaps in willingness to respond include concerns about worker safety. So we're seeing that in the news right now in hospital settings and nursing unions about concerns about lack of personal protective equipment or lack of understanding or availability of personal protective equipment. This has broad legal relevance in public health emergencies. And recent research actually by Peter Jacobson and colleagues at Michigan, University of Michigan, has highlighted a very interesting dynamic where there seems to be a disconnect between the existence of public health and other preparedness laws and frontline responders' understanding or even awareness that those laws exist. So what's potentially at play here is a tree falling in the forest phenomenon where you can have a very well-written law, but if those on the front lines are unaware of it because they haven't been trained about what laws exist or other related aspects, it's as if there is no law from their perspective. So there's an educational component here that hopefully these data will speak to. So when I first put together this PowerPoint, I did not have the graphic on the left of this slide. That's obviously a photomicrograph of Ebola. But we have to think about all hazards preparedness. And frankly, it's not just Ebola that is currently what needs to be on our radar. Frankly, in the U.S. currently, Ebola is more of a fear epidemic than a disease transmission epidemic. That's not, of course, the case in West Africa. But we have to think about not just Ebola, but newly emerging threats such as Middle East Respiratory Syndrome, H7N9, pandemic influenza threats on the horizon. And all of these come into play when we think about today's topic. So let's talk about an environmental scan that my colleagues and I did looking at a 50-state analysis of potentially influential public health emergency preparedness laws. So these data are as of June 2013. Of course, any kind of environmental legal scan is a very fluid process. But as of June of 2013, in just under half of the states, the government can declare a public health emergency. So that's quite a gap in terms of numbers of states that don't have that capacity or capability to declare such an emergency. About a quarter of the states at that time require the development of a public health emergency plan. I should probably add only a quarter of states have that written in at that time. Every state provides, however, some form of liability protection for first responders. 15 states give responders priority access to health resources. Those typically are in the forms of vaccines, although states in their laws about public health preparedness do not get into detail typically on the types of vaccines or the scope of that kind of priority access. And we really have a very patchwork approach, as you've probably been reading about in the news, if you're not aware of before. We have a very patchwork approach in the U.S. Toward public health preparedness law. It's a very state-based approach, and there's wide variation among states, including even not having the ability to declare a public health emergency at all, as indicated on this slide. So this patchwork approach really creates a complex system that can be very difficult to navigate and frankly creates a risk communication challenge when it comes to public health emergencies like we're currently experiencing with Ebola. Now, what I'd like to do now is transition to part one of our research in progress where we've looked at local public health workers' willingness to respond and broad issues relating to state law. So one of the fundamental questions we wanted to ask is there an association between a state's authority to declare a public health emergency and local public health workers' response willingness? So that's what we're going to talk about here. So just by way of brief background, in 2009, my colleagues and I implemented a survey called the Public Health Infrastructure Response Survey Tool, where we asked local public health workers about their willingness to respond to 4 representative scenarios across the all hazards continuum. And these are listed here: a weather disaster, pandemic flu, radiological dirty bomb, and inhalational anthrax bioterrorism scenario. We asked basic questions about demographics and attitudes and beliefs, and then we merged these data with data about the presence or absence of a state law that granted the state, a given state, the ability to declare a public health emergency. We focused our study on 8 clusters of local health department workers across 9 states. We also tabulated poverty level as one of our aspects for logistical regression. The reason for that is we hypothesized that areas that may have higher poverty level may likely have fewer resources to deal with public health emergencies and therefore a higher burden. The sample size for this was nearly 3,000 employees, 2,993. This was the largest study of the local public health workforce and willingness of its kind to date. And we were pleased with the response rate. We had a response rate of 66%, which gives us a sense of validity. However, just as a limitation of the study, it should be noted that this was a convenient sample with snowball sampling. So this is not a 50-state analysis, and there's more work that needs to be done to assess other states. But it does give us at least an initial indicator of where we stand with regard to the relationship between state laws and willingness to respond in local public health workers. So the bottom line is we did not find a relationship between the presence or absence of a state public health emergency preparedness law and whether or not, or the degree to which a local public health worker would be willing to respond. Now, that is a null finding. However, there are potential interpretations of this that we think are very relevant. One of the potential interpretations is that states rarely declare public health emergencies. What's going on now with Ebola is not the norm in terms of states that do have the ability to declare a public health emergency actually doing so. And this phenomenon, this lack of experience with being in the midst of a state-declared public health emergency may make local public health workers less familiar with the implementation of these laws. In any event, my colleagues and I hypothesized that we need to think about how local health departments at the institutional level can consider altering policies to promote response willingness. In prior research that I mentioned at the start of this webinar, we had found that leading modifiers of willingness to respond, or barriers, I should say, to willingness to respond, were concerns about personal and family safety, concerns about, and that includes concerns about being safe in the work environment, and mental health considerations, having access, for example, to employee assistance programs and other kind of mental health resources, because these workers are, like anyone else, in fact, in some ways more so, under stress given the challenges they're currently facing. So that is part one of our background. And in the remaining few minutes, I'm going to just talk about what I think is some intriguing findings that we have not yet published, but plan to, about hypothetical legal scenarios that, if they did exist, might modify local public health workers' willingness to respond. So this is, again, U.S.-based, but may have broader implications. So the objective of this particular study that I'm talking about now was to see whether the presence of 3 hypothetical legal protections actually influenced local health department workers' self-reported willingness for the 4 scenarios I mentioned earlier: weather emergency, pandemic flu, radiological dirty bomb, and inhalational anthrax bioterrorism. So I should mention that there are no existing codified laws of the kind that we're hypothetically describing here. Okay, so that's just, these are hypothetical, but they do have policy implications because you'll see the data that emerge from this. So we basically looked from our broader sample from the last study that I described at a smaller sample of local public health workers in 3 states, Florida, Minnesota, and Missouri. And we did the same approach to calculate statistics and fit logistic regression models accordingly. We had a 47% response rate to at least part of this survey, and the take-home message from this slide is that if local public health workers were provided with any of the following 3 hypothetical legal protections: access to mental health resources, that's one of them; family members getting priority access to treatment, and the third being public health responders getting access to personal protective equipment. The people who, if you gave local health workers those hypothetical scenarios, between 60 to 83% of them said they'd be more willing to respond. So that's actually a big increase in terms of willingness to respond, and a very positive modifier. So that speaks to the importance of revisiting current laws and seeing to what extent they address these critical areas. So even the lowest level increase, which was seen for the mental health services, that was between 60 to 63% agreed they'd be more willing to respond. So again, these are data that can drive policy, and that's the goal of this research. So in conclusion, based on our findings to date, it appears that specific legal protections, including priority response-related health care for family members, guaranteed access to mental health care for responders, and guaranteed access to personal protective equipment, can actually indeed augment a majority of local public health workers' response willingness. So that is the current research in progress. I've provided references here, and we'll be happy to answer questions subsequently. And my colleague, Dr. Lainey Rutko, and I are also very happy to answer questions subsequent to today's presentation. And at this point, I'll turn it back over to Rick. Thank you.
Daniel, thanks so much. And again, if anyone has any questions they'd like to ask Daniel or our commenters, please type those into the chat box in the bottom right of your screen. So we've got two folks we've invited to comment on Daniel's presentation today, Robin Gershon and Stephanie Garrity. Robin is a professor of epidemiology and biostatistics and core faculty in the Philip R. Lee Institute for Health Policy Studies in the School of Medicine at University of UCSF. She's also an adjunct professor at the University at UC Berkeley, where she teaches public health disaster preparedness and response. Prior to her appointment at UCSF, she was a professor in the Mailman School of Public Health at Columbia University. She also has previously served as the director of biological safety at Yale University. Got a lot of experience in public health research, and over the past dozen years or so, her research has focused on the barriers and facilitators for disaster preparedness, especially with respect to vulnerable populations and essential workers, including the healthcare and public health workforce. It makes her an excellent candidate to comment on today's presentation. And Stephanie Garrity is a health officer at Cecil County Health Department in Maryland. Stephanie was born in Baltimore, Maryland, graduated from Towson University with a BS in sociology, and from Wilmington College with an MS in management. She's worked in leadership roles at both private and public sector agencies for over the last 20 years. In 2003, she was named Deputy Health Officer for Cecil County, Maryland, and she became the health officer in 2008. So, Robin, would you like to start us off?
Thank you so much, Rick. Can you hear me okay?
Yes, we can.
Oh, great. First of all, thank you so much to Dr. Barnett for this exciting and very novel project. I'd like to speak to four particular aspects of the study that I found especially interesting and informative. First of all, this body of work adds a completely new dimension to our discussion of willingness to report to duty. There have been many, many studies before this looking at the motivations of essential workers to willingly report to work during times of crisis, but prior to this avenue of research, including the team's very recent paper on EMS willingness and state emergency laws, this line of inquiry has never, to my knowledge, been previously explored. So hats off to this group because this was an unknown charted area. The importance of this work is undisputed. Non-illness related absenteeism could severely impact the ability to meet surge demands. The second aspect of this exciting work by Dr. Barnett and his colleagues is that willingness intentions can be quite low for certain particular scenarios. But interesting, over the past few years, we have not seen any dramatic trends across various essential work groups. In general, intentions range from about 50 to 60% across most groups, except for emergency departments and EMS, which are the highest, and for prison workers and home health care aides, which are the lowest. So we haven't seen any push really upwards, which is kind of frightening in a way. public health workers typically rank among the most willing. However, the data that Dan is showing here is indicating to us that states' laws, these emergency laws, may actually help improve upon that. Studies have shown that when trust in the employer is high, willingness is also high. So anything we can do to improve that climate of trust may be very helpful. And this is underscored by the very recent reports out of Emory and University of Nebraska, where they actually have wait lists of healthcare workers who want to work in these specialized biocontainment hospital facilities. These workers are willing to work in risky situations if they feel that their employer has their back. Now, to the extent that they feel their employer has these state laws behind them, protecting them is another issue, and that, of course, is what Dan is so nicely trying to delineate for us. The third comment I have is that Dan clearly pointed out for us the high degree of variability that exists regarding states' emergency laws. Very few have adopted the best practices as exemplified by the Model State Emergency Health Powers Act. This is very concerning, and over the course of the years, the past few decades, we've hardly seen any movement to improve upon that. But these recent and unfolding events related to Ebola in the U.S. gives us a clear indication of the confusion that can result when you try to implement laws during a health crisis. Communications regarding the laws is very important, but as Dr. Barnett so nicely pointed out, many workers, including public health workers, and maybe in particular for public health workers, many workers are completely unfamiliar of their state's laws or absence thereof. So we have a huge opportunity here for education and communication. Fourth, the hypothetical scenarios that Dan provided for the laws on PPE, for instance, are very interesting to me in particular. And it tells me that local health department workers, as well as healthcare workers who have priority access, and of course priority access to health care for themselves and their family, may be more willing. But the problem for me, as I pointed out to Dan earlier this week, is that there may be limited resources. In that case, how will you balance that priority for public health workers, for instance, versus frontline healthcare workers? That is something that I don't think anyone has really looked at yet. Much, much more research is clearly needed. I've been focusing on the psychosocial factors that would help motivate people to be willing, but we really need to better understand the role of these emergency public health laws on workers' willingness, especially when there may be a disconnect or some conflict between federal versus state laws, as we're starting to see unfold in this dynamic situation we're currently in. In closing, I think this was an incredibly important and timely study, one that will hopefully serve to provide an impetus for states affecting policy change. And I'm curious, and hopefully Dan will address, how does he think this data could serve as that impetus to states? Like, who is the natural audience for this incredibly valuable information? And I'll end there, and thank you.
Robin, thank you. Stephanie, would you like to follow up?
I'd be happy to. Thank you very much. And I, too, echo my thanks to Dr. Barnett and his colleagues for putting this study together. I think the study conclusions validate what we are currently doing in local public health in the state of Maryland, and that is local health departments should consider altering their own internal policies to promote response willingness among their employees. And I'd like to speak briefly about some of the things that we have done and are currently doing to elicit a better response from our local public health employees. If I don't have a good response, I cannot mount a response, and the public is expecting me to do so. So some of the things that we are doing in local public health in the state of Maryland is that we have modified our state of Maryland job descriptions to include language that requires employees to respond so that new employees entering the public health system understand from day one what their responsibilities are. And an example of the verbiage that we use is this. At the direction of the health officer, the employee is required to respond to a public health emergency or natural disaster. State of Maryland tort also gives employee protections from personal liability unless, of course, there is willful negligence involved. I would never, ever send anyone to a response without proper training. That's why just-in-time training is so very important. Employees are trained to do functions within their scope of knowledge. I would not ask a non-nurse to do nursing functions, for example. I would also not put any local health department employee in harm's way unless equipped with recommended personal protective equipment. So very, very important. And on top of that, the training for its use. As Dr. Barnett mentioned as well, it's very critical that local public health response planning make provisions to care for the employee as well as the employee's family. If the employee's family is taken care of during an emergency, for example, if there's prophylaxis that's available to respond to something, that employees' families get that prophy first and as quickly as possible, including all other first responders in our community and their families. Also, it's very important to have a mental health component both in the planning, response, and recovery phases for short-term support as well as long-term support. And I think Dr. Barnett touched on employee assistance plans, and the state of Maryland offers that to its employees as well. And all of these things that I just mentioned are a part of our planning process and our planning documents and are exercised as well. So in closing, I would like to say, again, thank you to Dr. Barnett for this study. And also, I think what better way to show why employees chose to work in public health than to respond when needed. And that's my job as health officer, to give them the tools that they need to be responsive. Thank you.
Stephanie, thanks for your comments. We don't have any questions yet. Dan, did you have any kind of response to what Robin and Stephanie had talked about?
So I want to thank both Robin and Stephanie for their excellent comments. I think one of the points that Robin made is how can we translate these findings into operational change. And I think, frankly, one route is are forums like this, where these are opportunities to translate research into policy-relevant assessments and convey those. I think that health departments, and I'm very fortunate to have Stephanie as a colleague, have really, I think, taken a very important set of steps over the past few years to look out for their workers' needs, both physical and mental health, in terms of planning activities. And I think that, frankly, health officers can champion these particular issues at the state level where, in cases when some states may not have such laws. So I think, the practitioner is the ultimate stakeholder who can really convey these translated research findings to policymakers, in addition to the work that we're doing to convey these kinds of findings to policymakers. So those would be my initial thoughts to their very excellent comments.
Thanks. So we do have a question from Glenn Mays that he typed into the chat box, and it is, what do we know about the role of statutory law versus other forms of policy that can offer first responder protections, e.g. in the absence of a state statute, would a governor's executive order or a health officer be sufficient to motivate willingness to respond?
Oh, that's a great question. So the legal environment on this front is very fluid, and while we looked at state laws, there are statutes that flow from those state laws that vary greatly and that can change over time. So the short or the long answer to a short question is we don't know. specifically the extent to which statutes per se have that kind of impact. We hypothesized, based on our findings, that they would have a significant impact given these hypothetical scenarios, which we found would indeed change local public health workers' willingness in a favorable direction, but that is an area that requires further study.
Great. And we have a question that Robin Gershon has posed. Her question is, what might explain the lack of states' emergency public health laws? What might explain kind of just that lack of a law, period?
An excellent question, one that has not been examined per se. Frankly, some of it may be politics. There are some states where government is viewed more favorably than others in terms of intervention or oversight. And while that's just a hypothesis, it's one that's worth exploring. I think what we're seeing now during the current Ebola situation is that people who are looking for guidance in many cases are seeing a patchwork of guidance that is frankly confusing to the general public. It's confusing to residents of various states. And so, but the core rationale for why some states do and some states don't is an open question, I think, that needs to be resolved.
Looks like Glenn might have another question. He's typing right now, so let's just hold on for a sec. And then Glenn has a question regarding the first kind of batch of results you talked about. So regarding your study number 1, how much within state variation did you find in willingness to respond relative to between state variation? And could that kind of explain the null finding there?
Excellent question. So in our first study, 3 of the states, so we had 9 states covered in that study. 3 of them had in their state codified laws the ability to declare a public health emergency. 6 did not. But even within those states that did have that ability, we weren't able to find granular differences sufficient that we could explain variations within those states that did have that ability. But we were at least able to do a binary assessment. Did a state have that ability to declare a public health emergency versus not? So again, another exciting and important additional research question that needs to be answered.
I feel like there's a lot of ways to go to kind of explore this further. Looks like Robin might have another question. She's typing right now. So her question is, what is the role of federal law during epidemics and pandemics versus state laws? So obviously we've got federal and state laws that both might, to some degree, kind of determine what does and doesn't get done. So what are their respective roles?
Right. So very good point. So state laws ultimately trump the federal laws in terms of most circumstances that we're talking about, even with the current Ebola scenario, where you're seeing this variation in state laws that are really superseding anything that's coming from the federal level. CDC can provide recommendations, but it is not a regulatory agency. It does not dictate to the states in terms of how they would implement these various measures. They can provide feedback and guidance, but again, it's really a state-driven system. Now, for disasters generally, there's the Stafford Act. There are all sorts of federal, disaster declarations that states request of the federal government, and that causes a whole sequence of events to flow. But it's very important to distinguish between disaster law generally and public health emergency law. Those are 2 different scenarios. That goes back to some of our 50-state analysis findings, where fewer than half of the states, based on that snapshot in time, had a public health emergency or the ability to declare a public health emergency.
All right, then we've got a question from Glenn Mays again regarding the current Ebola responses in New York, New Jersey, and Illinois. Is there evidence that quarantine orders for responders deter their willingness to respond? So is there a negative impact there?
Well, frankly, this is literally off today's headlines, so it's too soon, unfortunately, we don't have good data, either from past research or current research, to say yes or no. It does seem like a logical working hypothesis, though, to believe that if a public health worker or a healthcare worker generally is going to have an additional 21 days of very draconian quarantine imposed following a very difficult and potentially traumatic experience in West Africa to begin with, that might be a deterrent. But that is just a hypothesis and frankly requires study. This is really a natural experiment in itself, what's going on right now, or a potential natural experiment.
Looks like there are no more questions. So thanks again, Daniel, for your presentation. It's fascinating and very timely, obviously. And we appreciate you being available today.
Thank you.
And just to remind everyone on the call, we've got 2015 PHSR Keeneland Conference, April 20 to 22nd this year, 2015. Our call for abstracts deadline is December 10, 2014. You can see keenelandconference.org or publichealthsystems.org. Can both give you more background and information on the conference. And then our future webinars, we've got one scheduled November 12th from 12 to 1. Trends and Characteristics of the State and Local Public Health Workforce by Angela Beck. And then December 10th, we've got Integrating Public Health and Healthcare, Lessons from One Urban County by Eric Carlton. So for more information, please contact Ann Kelly, the project manager of this, the NCC PHSSR, at ann.kelly@uky.edu. Thank you so much for your time today.